local School of Tropical Medicine, who is our partner in this project, Dr. Ahmad, the directors from your respective institutes who are around this morning in this event, their distinguished guests, our experts from various institutions, including those from State University of Zanzibar and other partners universities, the DVCs, academic from State University of Zanzibar and University of Dodoma, the distinguished guests, member of media, ladies and gentlemen, Assalamu alaikum and very good morning. A warm welcome to you all. It is with great pride and honor that we at the State University of Zanzibar have an opportunity to host this knowledge, learning and management meeting focusing on integrated quality improvement for HIV, TB, and malaria in international and post-medical care services. We are truly excited to bring together such a diverse and distinguished group of individuals and organizations, all dedicated to advancing maternal and newborn health care. May I take this opportunity to extend our heartfelt appreciation to you, Your Excellency Mama, for accepting our invitation to bless this gathering. We understand the tight schedule you have in the weekdays, but spare your good time and to share your moment with us. It gives us a lot of pleasure, and we really appreciate. This demonstrates your profound interest and commitment to the enhancement of social services, including health care. For the people of Zanzibar, we sincerely thank you for your presence. Dear guests of honor, these events mark a critical moment in our journey to improve the health care and well-being of mothers and their babies, both here in Zanzibar and beyond. Today, we are joined by the stakeholders from across the various sectors. These include researchers who are pushing the boundaries of innovation, policymakers, and who shape the future of healthcare, and the practitioners who bring these visions to life on the ground. It is our collective expertise and commitment that will drive the meaningful changes needed in the maternal and the newborn health. At the heart of this event is the recognition that research and innovation are powerful tools for addressing the pressing challenges we face in the maternal and newborn health care. The work that many of you are doing in HIV, TB, and malaria care is a treatment to how knowledge and research can create lasting solutions to complex problems. By continuously seeking our new ideas, embracing the evidence-based practices, and pushing the boundaries of what we know, we can build stronger healthcare systems, and that meets the need of our communities. Dear guests of honor, we also understand that power collaboration cannot be oversight. Today's meeting brings together the strength of academia, government, and international partners to create an environment where impactful interventions can take a shape. It is through these partnerships that we will be able to achieve better health outcomes for mothers and babies, not just by improving the healthcare services, but by influencing policies, strengthening systems, and ensuring sustainable development. Dear guests of honor, the State University of Zanzibar recognizes the significant efforts made by the 8th phase of the Revolutionary Government of Zanzibar, led by His Excellency Dr. Hussein Ali Mwinyi, to enhance the healthcare standards for its people. It supports in this mission SUSE is committed to build the capacities of professionals and practitioners and informing the government through the results of research conducted. We at SUSE have a number of schools giving lots of programs in academic, but with respect to issues of health, we have 2 main schools, schools of health and medical sciences and the schools of dentistry, where we offer about 5 programs in health-related degree programs and 7 diploma in health-related programs. We support the government by providing qualified graduates who are able to serve the community with a good heart. In support of this mission, SUSE is committed to build the capacity of those professionals and practitioners in that regard. We are dedicated to extend our academic collaborations with the various partners. As of now, we have a school of Liverpool Tropical Liverpool School of Tropical Medicine with us, along with the other partners from Kenya, mainly in Tanzania and Nigeria on that regard, ensuring that together we achieve our intended goals. In conclusion, I encourage each and every one of you to engage deeply in the sessions and discussions throughout this 3-day meeting. The knowledge shared here today has a potential to create a lasting impact, but its true power lies in how we translate it into practice to benefit our communities. Let us all commit to taking what we learn and apply in its way that we save the lives, improve care, and build the healthier future for the generations to come. Thank you for your presence, your passion, your dedication to this vital cause. Together we can make a difference. With that, I welcome all of you to the State University of Zanzibar, and beyond the academic arena, you are invited in Zanzibar. You can have a good moment here for those who are not coming from Zanzibar, and Zanzibar is a destination for you, and we shall provide you with all what you need here to spend your time and a good moment with us. With that remarks, I thank you for your attention. Thank you very much.
Her Excellency, First Lady, Republic of Zanzibar, and founder of the Zanzibar Mashabura Foundation, Mama Mariam Mwinyi, Honorable Minister of Health, Zanzibar, Honorable Nasser Ahmed Mazuri, Vice Chancellor, State University of Zanzibar, Professor Mohammed Makami Haji, Director Reproductive and Maternal and Newborn Health, Tanzania, Dr. Ahmed Mokwani. Distinguished ladies and gentlemen, good morning and welcome to our final Knowledge Management and Learning event. I bring you warm greetings from the Liverpool School of Tropical Medicine, which is the oldest school of tropical medicine in the world. And I'm glad so far nobody has made a mistake to call it the London School. It's the Liverpool School of Tropical Medicine. It's a mouthful, I know, but if you're struggling, just call it LSTM. One thing brings us all together is our passion to improve the lives of women and newborns globally. And reducing perinatal mortality and morbidity still remains a priority globally. And this is something we have tackled the world over for several years, and less than 6 years to the end of the Sustainable Development Goals, we are still faced with the same problems of having the burden of maternal deaths and deaths of children, deaths of babies, occurring mostly in sub-Saharan Africa and South Asia. WHO has recommended key priorities to help improve perinatal mortality, and these are commitments to investment in this area, planning and implementing for equity, so making sure that every woman, irrespective of the wealth of her household, her level of education, where she lives, will have the same quality of care. Now, this is critical. Also, to improve the quality of service delivery, ensuring that we are accountable and we use partnerships to achieve, to travel further and achieve those ambitious goals of improving maternal health. And also using data for improvement of care. At the School of Tropical Medicine, through the Emergency Obstetric and Quality of Care Unit that I lead, we support the WHO through these strategic priorities by partnering with several organizations to be able to achieve this. So on behalf of the Vice Chancellor of the School of Tropical Medicine, I once again welcome all of you. In the Emergency Obstetric and Quality of Care Unit at the School of Tropical Medicine, we conduct applied research and implementation research covering 3 key thematic areas. One is health system strengthening, the second is capacity strengthening for improved service delivery, and also quality of care. Well, we cover this through the continuum of care that we expect women to receive: antenatal care, intrapartum care, emergency obstetric care, and postnatal care. Once the baby is out, the danger is not over. Women can still suffer complications as a result of the process and even lose their lives even after the baby is born. We are quite conscious of this. And we're able to achieve all of this through strategic collaborations with academic institutions, just like the Vice Chancellor has said, academic institutions in sub-Saharan Africa, and with ministries of health in all the countries that we work. Most of our work focuses in those countries where we have the highest burden of maternal deaths and perinatal deaths. We also have strategic alliances which we help to further this cause. For example, the Alliance for Improving Midwifery Education, where we work with the likes of JPIGO, International Confederation of Midwives, and UNFPA to advocate for more resources and more investment into midwifery education. Most of you here are mothers, or you have sisters, or you have wives. When you go to the labor room, you know who you meet first is a midwife. And they are the forefront. I consider the obstetricians to be the backup. So you need to train these midwives to the highest quality because they are first on the scene to be able to respond. And this is something we strategically support within the unit. Within the unit, we're also part of strategic groups, working groups within the WHO. For example, the WHO Technical Working Group for Maternal Perinatal Death Surveillance and Response. This is a very good tool for improving the quality of care, learning from all the NSs, women that have died, so that we make sure that we don't make the same mistakes within our units. We're also part of the Technical Advisory Group on Estimation of Maternal Mortality and Maternal Cost of Death. if we do not count accurately the numbers and learn from those women that died, then we cannot plan for the future. And so the WHO leads that work to make sure that we have accurate estimation. That way we can track progress in terms of improving maternal and perinatal health. Also, as part of supporting member states through the Africa Union, we have supported the development of a strategic priority document to advance the Maputo Plan of Action for improving sexual and reproductive health rights on the continent. And through the reproductive health unit of the Division for Disease Prevention and Control, we're able to support this initiative. We're here today because, with generous support and funding through the Global Fund from Takeda CSR, we've been provided with generous funding to work with partners in Nigeria, Tanzania, and Kenya to improve the quality of care during antenatal and postnatal care, and making sure that some of these deadly infectious diseases, we're able to detect them early and respond better during pregnancy and childbirth. The program has been implemented since the year 2020 and ends in December this year. But from the third year of its implementation, we introduced the knowledge management and learning events. Now, these were strategic opportunities to facilitate South-South learning. We don't always have the answers to the problems. Most of the time, it's not because we don't, that evidence of how to treat conditions do not exist. But the way you implement those evidence in one setting to the other differs, and that was what makes a difference. So we have to have a system where we learn continuously to improve care. And so we created this platform, for key stakeholders, Ministry of Health, research partners to come and share knowledge and learn for improvement. For this KML, which is our final one in this program, what we want to do is to be able to recognize the change agents. So these are people who work in the forefront, people who work in our healthcare facilities, our partners in the academic institutions, and the Ministry of Health, who have been part of this process of change and the success which we have recorded. We want to be able to share results from the implementation research conducted. We want to share these best practices and lessons we've learned from the program. And finally, we want to be able to facilitate policy dialogue with our leaders in academia, with our leaders in the Ministry of Health, people who are responsible for policy, how we can take this forward. So over the next 3 days, I just summarized in my slides what you will expect. We're grateful, firstly, for your presence. It means so much to us, because we know that what we're trying to do aligns with your vision and with your passion. So this goes a long way. Her Excellency, we are looking forward to her keynote address and also formal opening of this event. We're going to recognize, the excellence of healthcare providers and partners. We're also going to recognize some of the key outputs from this program. And we're going to further describe the program interventions and some of the key results. In day 2, we're going to launch our podcast series, which is a series of fireside chats, where we discuss between implementers, beneficiaries, key stakeholders, what the benefits of this program are, and quite easy listening. And you can all download on your phones and listen at your spare time. We are also going to focus into learning about key research outputs by people, by researchers from collaborating universities in these countries. So these are not people who are UK people, but these are people from the countries, quite relevant, leading this research, this pieces of research. On day 3, we shall have an advocacy event, a fun run, which I encourage all of you to participate, to help increased advocacy for early antenatal care attendance, good quality of care. On day 3 also, we're going to have a sustainability dialogue, engaging with our stakeholders from education and training and service delivery. So dear colleagues, distinguished ladies and gentlemen, I welcome you, to this event, and I hope you're going to have a memorable time, really networking with colleagues. Within your packs, you will have access to this QR code. In the spirit of sustainability, we've not done a lot of printing, but you're going to see through that QR code the program, the abstracts, and a lot of relevant information about the program, including all of the welcome messages from our distinguished speakers. So I welcome you to visit our website. I want to take this opportunity to thank all team members, all stakeholders, partners, and especially the team from the State University of Zanzibar, led by Salma and the Vice Chancellor. They have worked relentlessly to put together this event. And also, we really thank the Ministry of Health for the warm welcome, the Office of the First Lady for facilitating things, and I hope and I wish you all, very fruitful deliberations. Ashanti Shans, thank you.
Chief Guest, Your Excellency, Mama Maria Mwini, the Minister of Health, Honorable Nasser Mwini, the VC, State University of Zanzibar, Professor Charles Kame, LSTM, Dr. Mangwani from Ministry of Health, Mainland Tanzania, all protocols observed. Thank you. All right, so all protocols observed. Thank you for the opportunity to be here. We really appreciate your coming, and I just want to bring to the attention of the chief guests and all participants, just to have an idea of who is in this room today. And I think in view of the numbers, we will not give everybody a microphone, but I will just go ahead and introduce all the people represented here in their specific groups. So I will go according to the countries. So the first group I would like to recognize is the presence of the team from Nigeria. And from Nigeria, we have an implementing organization called the Sanke Medical. And together with them, they have come with a representative of the Federal Ministry of Health and a representative from the state of Oyo State and Kaduna State. So I will ask all the colleagues from Nigeria to just stand up so that we can recognize your presence. Thank you very much. Next, I wish to request the group from Kenya. In Kenya, we have participants from the Liverpool School of Tropical Medicine, which is our office that is based in Kenya. We have representatives from the Ministry of Health. You know, Kenya is a remote state, so we have the counties and we have the Ministry of Health. And we have representatives from the 3 implementing counties, that is from Garissa, from Vihiga, and from Uasin counties. So my brothers and sisters from Kenya, please stand up so that we recognize your presence. Thank you very much. Okay, next to that is that we have our colleagues from mainland Tanzania. Mainland Tanzania, we have representatives from the Ministry of Health, led by Dr. Mangwani. We have the Regional Medical Officer for the Dodoma region. We have colleagues from the University of Dodoma, and I believe one of the districts represented here. So I wish to request all the colleagues from Tanzania mainland who have traveled yesterday to just stand up so that we can recognize your presence in this special event. Thank you very much. Thank you very much, Professor from Judo. And the other group to recognize is our colleagues from the Liverpool School of Tropical Medicine from our UK office, led by Professor Charles Amin. We have several colleagues who've been supporting in various aspects of this particular project implementation. And I wish to request all our colleagues from the UK office to stand up so that we recognize your presence. Thank you very much. We also acknowledge the presence of many colleagues from here in Zanzibar. We have colleagues from the State University of Zanzibar. We have a large delegation from the Ministry of Health led by Dr. Salim Slim. We have also some of the representatives from Pemba, and we just appreciate your courtesy and your hospitality when we are here in Tanzania. Please stand up so that we can recognize your presence. Thank you very much. And we have partners also who have joined us for this particular event. Specifically, I want to acknowledge the presence of a colleague from UNFPA Tanzania, Dr. Azza Said. Would you please stand up so that we recognize your presence? Yes, thank you very much for your coming. And last but not least, members of the Fourth Estate. Without you, whatever we do would never be known by anyone. So all the colleagues from the media, just stand up, raise your hand. We just want to appreciate the contribution that you make to our work. I think there are many others outside there. So thank you very much. So Your Excellency, this is the group that is here with us, and we look forward to a great interaction. We have shared a schedule of list of participants with some basic information. Of course, in view of data protection, we cannot provide numbers and emails, but at least you can see the names and their designations. We can make contacts, and we have time in the next few days to catch up with them. Thank you very much. Yes, so we have, as you've been told, this project has been funded by the Global Fund, from funds from the Takeda Pharmaceuticals, and we have two of our colleagues joining, most probably from Geneva, to just say a word, to recognize the work that we have done, and to welcome us to this particular meeting. So the people in charge of communication, please stream. So the two speakers that will be making remarks, first is Dr. Nicholas Futelo, is from the Global Fund. He's a senior medical advisor on health system and specifically on oxygen and respiratory care, but more so on resilient health system. And will be the one making the first remark. Then I will be followed by Rina Sakai, who is from the Takeda Pharmaceutical, who will also make a few remarks on that. Welcome, Dr. Futelo. Take it over.
This program has been implemented in 3 countries, like I mentioned earlier on, but also in 7 subnational areas, and these were decided in partnership with the various ministries of health. And within these subnational areas, there were 151 facilities that were supported under this program over this period of time. Based on the agreement under the program, we focused on 3 main tasks. 1 was to identify the bottlenecks to improving the quality of care. 2 was designing and introducing a quality improvement process at healthcare facility level. And 10 was to evaluate the effectiveness and efficiency of such design for programming. I will continue while we sort that out. So, what I want to present to you is, the theory of change that we have used for this program, which really defines what our inputs are, what the expected outputs are, what are some of the key outcomes, and what are the long-term effects of this program. So this program, ultimately we wanted to see effective coverage of antenatal care and postnatal care, but we wanted to achieve this through effective competency-based training of frontline healthcare workers in antenatal and postnatal care. We wanted to introduce a quality improvement program at healthcare facility level using the methodology of standard-based audits. And also we identified essential equipment that was lacking in these healthcare facilities and provided them. And this included equipment for point-of-care testing, essential things like testing for protein in urine, testing for anemia. So we provided the skills and the resources to perform those tests. And this, we will see from the results that were presented over the subsequent days, how this reduced the delay in treatment. Also, we introduced a supervision and mentorship program in the facilities. With this, we expected to see that antenatal attendance, postnatal care attendance improves, and the number of women who are expressing satisfaction with the quality of care also improves. And in the short term, quite cognizant that there are other things happening in the health system. We just trust to see what improvement will be in terms of perinatal and maternal outcomes. So based on this, I think at the starting point we did baseline assessments in collaboration with the ministries of health to identify those areas and those items that needed improvement in terms of basic equipment, within the healthcare facilities. These basic equipment were procured and handed over to the Ministry of Health for distribution to all of these healthcare facilities. And we could tell, straight away from the testimony of the healthcare providers how this will make a difference. Because of some lapses in the health system, even some equipment procured centrally may not make it timely to those remote healthcare facilities. But we're able to work with the Ministry of Health to unblock this problem. Healthcare workers trained, expressed a lot of satisfaction with the quality of training they received, and they were really energized to provide better quality care going forward. I just made the slides we're showing. I have some, very good pictures to show you some of these things I'm talking about. We were able to also ensure that this point of care testing was taking place within the healthcare facilities. And this was to a lot of satisfaction of the healthcare providers, but also the women in the healthcare facilities. Now, as part of this entire process, we put in a monitoring and evaluation framework, which was quite essential in terms of helping us to track achievements. Helping us to track achievements of our objectives, to help us to correct course if we're not going to plan. All right. So we put in a monitoring and evaluation framework to help us track achievements of the expected outcomes and the outputs from all of the activities. And I'll just share, Your Excellency, some of the key results. We will have, the next 2 days, we will dive into details of all of this, but at least for the benefit of those on the high table, I'll share some of the key results. In terms of total antenatal care visits, this improved significantly across all countries and was really maintained from the first quarter until the end of the program. One area where we struggled with was increasing the number of women attending within the first trimester, in all of the countries. And I think we had the assumption that women who come to the healthcare facilities receiving good quality of care will go back and tell others and they will come. But I think we found out that we probably need a bit more of community work to generate that demand. I think that's a key lesson from this program. Also, regarding postnatal care attendance, this increased significantly across countries, all of the countries, achieving even above 80% in countries like Kenya and Nigeria. Regarding the crude steel birth rates, now this showed a downward trend, from the start of the program until the last quarter of data collection. In terms of maternal mortality, like I said, some of these things we have to track. We cannot say exclusively this program, resulted in this effect we're seeing. But we strongly believe that this program has made a contribution to the downward trend in maternal mortality we've seen in those supported facilities, 151 facilities across the 3 countries. In terms of those point of care testing, looking at HIV testing, anemia testing across all countries. Now, this remains quite high and on upward trend across all quarters monitored. Now, something else we are quite proud of in this program is the work we've done with the collaborating institutions in the country. So the institutions of higher learning. We agreed with the Vice Chancellors on a mechanism to improve research capacity in those institutions. And one way of doing that was work with the university to select suitable candidates for them to take a PhD program. And I'm happy to report that all three candidates, two from Tanzania, one from the mainland, one from Zanzibar, and one from Nigeria, they are all in the final stages of their PhD now. So this is something we are very proud of. Tomorrow will be dedicated to their work, so you will listen to all of the great work they have been doing, and we hope that this will also inspire those postgraduate programs within those institutions. So some of the topics they are working on. So Maria is working on effective coverage of antenatal care. Zainab is working on the comparison of comparing two approaches to capacity strengthening of healthcare workers, whereas Umi from Nigeria is working on domestic abuse and violence, and also mental health, mental illnesses during antenatal and postnatal care. So I just encourage you to come and listen to some impressive talks tomorrow about all of this. So I'll conclude by once again apologizing for the failure in the tech. You cannot see my slides, and you will have to believe whatever I'm saying. And I hope I painted the right picture in your minds. And I think the IT team has probably had to correct some of the glitches we have faced so far. Thank you so much.
Your Excellency, Maria Mwinyi, for agreeing to come today to grace this event. I would like to thank waziri wetu Zenaso for again convincing Her Excellency to come to this event, because I understand without you this wouldn't be possible. I would like to again to compliment to Honorable Minister for leading us to United Nations General Assembly. Our technical team was led by Honorable Minister. I understand also Your Excellency were there. But I would like to compliment him for leading us, the team, going to the General Assembly and delivering the technical speeches, particularly those responsible for the antimicrobial resistance. It was a very echoing statement from the United Republic of Tanzania, which was read by him. Thank you very much. I thank Professor Charles Germain, my colleague from Liverpool School of Tropical Medicine. We happen to work together in the same office. And quite often we have been remembering Tanzania, that there's somebody in Tanzania. And thanks for bringing this Burudani in Tanzania, which has helped people in the Dodoma region, but also in Zanzibar as well. And although we are closing up, it is possible that it is a start of a new chapter, of moving forward, so that we can work together, so that we can at least making sure that our women's and children's get good services, as well as the first world does. I understand you have come in Zanzibar with that team from specifically Liverpool. The Liverpool people, welcome. I don't speak the Liverpoolian, but at least I would say welcome here. And when you are in Zanzibar, there are places to visit. In the evening, I think we should be arranged to take you to seashore so that you can enjoy the different types of food here. They are very good food. But also when you have time, you can visit some of the tourist attractions, including movie and the others, so that you can enjoy the hospitality of Zanzibaris. Welcome to Zanzibar. So, without much ado, my duty is so simple. First of all, receive greetings from the Tanzania mainland Ministry of Health. The team is keen to support each other. We have supported you a lot in various areas. You take our guidelines, we take your guidelines. We exchange. That is the normal going of Tanzania, and Zanzibar. So you receive these warm greetings, and we hope that this program is reaching to an end. We will continue this collaboration for the betterment of our people. Without much ado, I would like to take this opportunity to invite Honorable Nasser Ahmed Mazrui, Minister of Health, Zanzibar, come and deliver a speech, but again invite the guests of honor. Karibu sana.
Your Excellency, the First Lady of Zanzibar and the founder of Maisha Bora Foundation, Dr. Salim, Director of Occupational and Health Education, Minister of Health Zanzibar, Professor Mohammed Makame, Vice Chancellor of the University of Zanzibar, Dr. Ahmad Makwani, Director of Operative Maternal and Child Health, Minister of Health, Tanzania, Professor Charles Ame from the Liverpool School of Tropical Medicine, Madam Manisha Faki, Director of Nursing and Midwifery, Zanzibar, Deputy Vice Chancellor UDOM, Professor Razak Rokina, Deputy Vice Chancellor Suda Dr. Makame Musi, representatives from Ministry of Health of Nigeria, Kenya, and Tanzania, distinguished guests, ladies and gentlemen, Assalamu alaikum, and good morning. A warm welcome to all participants on behalf of the government of Zanzibar. We are honored to host this third Knowledge Management and Learning KML event here in Zanzibar, focusing on the quality improvement of integrated HIV, TB, and malaria. Integrated HIV, TB, and malaria services in antenatal and postnatal care is very, very important project for us. The location of this event in Zanzibar underscores the nation's strong commitment to improving maternal and newborn health outcomes. We are particularly proud that this year's KML meeting coincided with the end of a collaborative program with esteemed partners, including the State University of Zanzibar and the Liverpool School of Tropical Medicine. The importance of integrated health services, particularly the crucial intersection of HIV, TB, and malaria with antenatal and postnatal care, cannot be overstated. The Ministry of Health has deeply invested in fostering partnerships with international bodies, universities, and NGOs to enhance healthcare delivery across Zanzibar. That collaboration we celebrate today with the London School of Tropical Medicine, the State University of Zanzibar, and the Nobel Fund has already made significant strides in 10 healthcare facilities across Unguja and Pemba. Excellency, guest of honor, your presence here indicates clearly your serious commitment toward the improvement of health for mother and children. We, the Ministry of Health, appreciate your unwavering support to our ministry, toward health care for the people of Zanzibar. Thank you, Your Excellency, for your support. And before I conclude, I would like to thank my beloved President. Let me correct my last statement. It was State University of Zanzibar and Liverpool School of Tropical Medicine, and not London. Before I conclude, I would like to thank my beloved President, Dr. Nini, for the commitment toward the health care of all Zanzibaris and his great support to the Ministry of Health. My President is supporting me highly, and this makes me stronger to work tirelessly. Thank you. And in conclusion, I express my sincere hope that the discussions and knowledge shared here will translate into actionable steps toward building resilient health systems in Zanzibar and beyond. The Ministry of Health will continue to support these 10 healthcare facilities to ensure that the achievement of this project are sustained, providing quality healthcare services to the community of Zanzibar. And finally, I provide great thanks to Global Fund, Takeda, Liverpool School of Tropical Medicine, and especially my friend, Professor Charles. Professor Charles has been very active in this project, and I know him personally because he was calling me all the time. And thus was built interaction between the Ministry of Health and Professor Charles. Thank you, Professor Charles. So Takeda, Liverpool School of Tropical Medicine, and the State University of Zanzibar for your contributions. And I extend a heartfelt welcome to Zanzibar. Zanzibar ni njema, atakaye na aje. Feel at home and welcome. Ndugu zangu, aitie kwa kusha. Hamutuletea hapa. Mimi sipendi kufuta picha. I'm not here with you. After saying so, now let me and all of you join with me to welcome Her Excellency Madam Winnie, the First Lady of Zanzibar, to this my speech. Thank you very much. Welcome.
Honorable Ahmed Mazrui, Minister of Health, Zanzibar, Professor Mohammed Haji, Vice Chancellor of State University of Zanzibar, Professor Charles Ahmed, Head of Department for Maternal Health, Liverpool School of Tropical Medicine, Dr. Ahmed Makuani, Regional Medical Officer, Dodoma, representatives of ministries of health from Kenya, Tanzania, and Nigeria, esteemed healthcare workers, professionals and partners, distinguished guests, media group houses, invited guests, ladies and gentlemen, Assalamu alaikum, good morning.
Good morning.
Good morning. It is a great honor for me to address you at this very important meeting
Your presence here today demonstrates your commitment to this very noble cause. This program aligns not only with the Zanzibar government's priorities to improve women's and children's health, but also with the priorities and ambitions of an organization that is very dear to my heart. Distinguished guests, ladies and gentlemen, the Tanzanian Demographic and Health Survey of 2022 indicates that bottle feeding is more common in Zanzibar at 13% than in mainland Tanzania at 5%, an issue that influences nutritional outcome for infants and children under 5. The survey also reveals a significantly higher prevalence of anemia among pregnant women compared to non-pregnant women. Furthermore, the high consumption of sweet beverages and unhealthy foods raises a red flag regarding the potential dietary risks for pregnant women. These figures should be a cause for concern for all of us. Additionally, 17.6% of children under 5 are stunted, while only 67% of households consumes at least 3 meals daily, and poor nutrition habits make malnutrition a concern. Moreover, maternal mortality rates are still very high in Zanzibar, similar to other regions in sub-Saharan Africa. The current maternal mortality ratio in Zanzibar is at approximately 145 per 100,000 live births. It is for this reason that I'm glad to learn of the work of the Quality Improvement and Integrated Program funded by Takeda's Global CSR program through the Global Fund has been addressing 4 major contributors to maternal health complications as follows. First, early detection and treatment. The program enhances early detection of maternal health risks through regular screenings, allowing for timely interventions. Secondly, capacity building through training and mentorship. Healthcare workers are better equipped to manage complications related to pregnancy, delivery, and postpartum care, improving maternal outcomes. Third, community engagement. The program promotes community awareness of the importance of early antenatal and postnatal visits, leading to increased service uptake and earlier interventions which can prevent maternal deaths. And fourth, holistic care. The integration of maternal health infectious diseases management ensures the pregnant women receive comprehensive care, reducing the risks of comorbidities that could lead to fatalities. Distinguished guests, ladies and gentlemen, as some of you know, the Zanzibar Maisha Foundation, which I founded in 2021, is deeply committed to attaining quality life for all women, youth, and children in Zanzibar. We are working towards a mission to involve women, youth, and children in socio-economic empowerment to attain a quality life through 4 strategic goals championed by 3-year strategic plan 2022-2025. This plan aligns with several development frameworks, including the Zanzibar Development Vision 2020 to 2050 and the African Union Agenda 2063, which outlines a vision for Africa for the Africa we want, and is designed to contribute to the achievement of United Nations Sustainable Development Goals by 2030. Zanzibar Maisha Bora Foundation has played a significant role in addressing these challenges through its Afya Bora Maisha Bora campaigns. It's a medical outreach initiative aimed at strengthening community-led primary health care by creating holistic access to health care. Through this campaign, to date, we have provided health services to over 24,767 community members, including 395 pregnant women who have never attended a clinic and have been referred to prenatal care. These women were identified during the community-led village health and nutrition day intervention, which provide vital checkups and referrals, ensuring they receive the necessary prenatal screening to protect both their health and the health of their babies. Furthermore, through household-based interventions, we have been able to reach 5,742 women with health and nutrition education, primarily emphasizing the use of locally sourced foods. Through targeted interventions, we have provided nutritional care to the most vulnerable children and pregnant women by leveraging community health workers supported by the Ministry of Health and funded by the World Food Programme. This integrated approach, combining nutrition and maternal health, has proven to be highly effective and ensured the nutrition education and healthcare services reach even the most remote households. Distinguished guests, ZMBF is also integrating seaweed research into a nutrition program, as we believe seaweed is an untapped resource with immense potential to improve both nutrition and local economies. The research aims to develop strategies for marketing seaweed products while enhancing their nutrition value. The goal is to establish seaweed as both an economic driver and a dietary staple for pregnant women. The success of our pilot program and the integration of seaweed into strategies demonstrate the power of community-driven, multi-sectoral approaches. However, none of this would be possible without collaboration. We are eager to deepen our partnership with organizations like Global Fund, Takeda, and other development partners who share our vision in improving maternal, newborn, and child health outcomes. As we look to the future, I envision Zanzibar where every child grows up healthy and strong, where mothers are empowered to nourish themselves and their families, and where malnutrition becomes history. To achieve this vision, collective effort from governments, NGOs, development partners, and communities is essential for ensuring quality life for all Zanzibaris. Distinguished guests, I express my gratitude to the Liverpool School of Tropical Medicine, the State University of Zanzibar, and Ministry of Health for their dedicated efforts to enhance access to quality maternal and newborn care. Your work has improved antenatal care coverage and strengthened the capacity of our healthcare providers, including nutrition counseling and the management of anemia in pregnancy. Beyond healthcare, addressing food security is paramount. Empowering our communities to adopt healthier dietary habits especially by increasing The consumption of fruits, vegetables, and nutrient-rich foods will help ensure a healthier future for Zanzibar and Tanzania at large. With these remarks, I wish you all successful discussion that will contribute to the improved health and quality of life for women and children of Zanzibar and beyond. I also encourage you to take time to enjoy the beauty and warmth, hospitality of our people here in Zanzibar. With these remarks, I now declare the third and final knowledge management and learning event of quality improvement of integrated HIV, TB, and malaria services in antenatal and postnatal care program officially opened. Thank you for your attention. Karibuni sana Zanzibar.
So that is one very good practice. Also, you're able to identify that to reduce on the 5 mortality rates, what you really need to target is the neonatal mortality rate. And if you can address that, then that whole thing comes down. So that's maybe a strategic focus in the short term, and in the long term, maintain that, but also address all the other causes of under 5 mortality. And I think something I really like about the presentation is also linked to what I said in my talk about those WHO strategic priorities recommended to reduce perinatal mortality, was the issue of accountability and tracking progress through the use of data. And the scorecard was introduced in Tanzania probably a decade ago, and I think he has demonstrated clearly they've held themselves accountable to certain key RMNH indicators. What it was when they started, you could see from the slide, it was you had much more red than amber, let alone green. And by last year, you can see that that scorecard was predominantly green. So that is really fantastic. So they're taking charge, taking leadership, holding themselves to accountable, and also that sets the stage for the sort of approach that they expect their stakeholders and partners to apply. Finally, he talked about their approach to maternal death surveillance and response. Usually, when you talk about this to healthcare workers, people are afraid about being blamed, being shamed. But I think we can see from Tanzania that most healthcare workers have embraced this as a method for improving accountability, quality of care, and again, they have come to the same conclusion, the importance of improving healthcare worker competence to provide good quality care. And this is one area that our program has tried to strengthen. So Dr. Makwani concluded by, with an advice. First, we need to improve availability of services and evidence-based services, but also making sure we address the issues of equity, quality of care, and affordability. So the care can be of good quality, but if women, irrespective of income, where they live, level of education, cannot access, then it is no good. The biology of a woman in Canada is not different from the biology of a woman giving birth in Africa. It's the same. Oxytocin will work, it's just going to work. So we need to address to make sure that every woman has access. So Dr. Makwani, thank you so much for your contribution. So swiftly we're going to move on to Dr. Bashir. So Dr. Bashir is the Director of Family Health, Ministry of Health of Kenya, and he will be giving us the Kenya perspective. Welcome, Dr. Bashir.
Good afternoon, colleagues. I don't have a presentation like my able brother Ahmed, but I will touch on the similar presentation on my phone. In Kenya, we've invested a lot in maternal and child health in the last decade, but our statistics have not moved. And we are grappling with that, we are dealing with that. We believe it's measurement issues and modeling issues. And as we do that, what has stagnated mostly is the maternal mortality ratio and the newborn mortality. We've put all those interventions that Tanzania has put, except that we may not have been very aggressive about the quality of care, which we are on now. So the outcome indicators that we have in Kenya, the KDHS on antenatal care is nearly 98%. So we have only 2% who are not attending our antenatal care. These are proxy indicators: family planning prevalence, skilled birth attendance, antenatal care, postnatal care. All these are supposed to be proxy indicators on reduction of maternal and newborn and child health. We've made some progress on infant and under 5. In fact, under 5 is very good. But the mother and the baby, the newborn, have not moved an inch. 2/3 of the women, 66%, had at least 4 ANC, and only 4% had the 8 recommended ANC visits. 29% had their first antenatal visit during the first trimester, so we see now where the problem is. The recommendations are that the earlier the better, but over 2/3 of our women are coming after first trimester. 90% of women took some form of iron supplementation, and 28% took deworming medication during pregnancy. In addition, 75% received sufficient tetanus toxoid injection to protect their babies against tetanus. That's where we are on our antenatal care. As far as delivery is concerned, our skilled birth attendant has moved from 60 to 88% or 89% as per 2022 DHS. 11% of the births were delivered at home, and some of the counties, the issue of equity now comes in to play. Some of the counties in the arid and semi-arid areas have more than 50% of their deliveries at home. So that could be a factor that's contributing to our high mortalities. Mandera had 50%, Tanzania had 48%, Turkana 47%, Wajir 46%, and Samburu 45%. And there are about 20 counties in the nation that are classified as arid and semi-arid, but about 10 to 12 of them are really arid, and all the social development issues, the health determinants of health are really poor, and that would be a contributory factor. 70% of the live births are delivered by cesarean section, that is as close to the 15% maximum that the WHO recommends. For postnatal care, we have 83% of most recent live births receiving a postnatal care checkup within 2 days after birth. However, 16% received no postnatal check in 2 days after birth. Only 54% of newborns had all the 5 signal functions performed during the first 2 days. We have 83% postnatal care, and only 54% of the newborns got the 5 signal functions that they are supposed to receive. This is an indicator of quality of care. And 25% of postnatal mothers had 3 checks performed, postpartum postpartum eclampsia can come up. Postpartum eclampsia can come up after delivery. Once the baby is out, that's not the end of the game, both for the mother and for the baby. So blood pressure measured, discussed FP. It's a very golden opportunity for you to really space the children if they want more kids. If the mother has decided that she has her desired family level, then it's the most important time to discuss FP and maybe monitor the vaginal bleeding. Some of the interventions as a country we have put in place to prevent maternal and newborn deaths is improving quality of maternal and newborn care is MPDSR. We started MPDSR long ago, and quite a number of our maternal deaths, maybe in the range of 80%, are being audited. We've also done, I think, 2 confidential inquiry of maternal deaths as a country. Recommendations and annual reports are there. We're disseminating them to the counties because we have a different system now involved healthcare, where service delivery actually goes to the counties, and the national level is just to help put policies and capacity building in place so that the implementation actually happens at the county level. As a nation, we've done MNH Quality of Care Standards in 2022, which is a policy guideline on improving quality of care using standards. And for the first time, we usually have every 4 to 5 years our facility-based service assessment survey. This year, last year, we've just concentrated on quality of care, harmonizing quality of care, especially in maternal and child health. We have our report, and it's being implemented and disseminated to the counties. So we've realized that the quality of care is the impediment, because we made service delivery free through the Linda Mama program, where any mother who's pregnant gets full services end-to-end for free, and they don't have to pay. So, therefore, the standards are there. The survey has been done to confirm that we really want to improve on the quality of care. There's also increased coverage of IMOM in terms of infrastructure development. The counties are very handy in ensuring that we have the right numbers of IMOM and BIMOM facilities, and they have put up a lot of, they have employed a lot of health workers, and they have also put up a lot of infrastructure in terms of health facilities. Then we've done also what's called the National PPH Action Plan, which is being rolled out, is a rollout of evidence from the e-motive study. I'm not sure if Tanzania was part of that study, but because PPH contributes to more than 30%, a third of our maternal mortality, we were part of a global study on the e-motive study, and the results are being now rolled out. The action plan is being rolled out in the country. Then there is a national action plan on EPMM and ENAP. I'm sure many of the sub-Saharan Africans are on this. ASC coverage, skilled birth attendant, PNC, EMOC coverage are the indicators that we are monitoring in this action plan as we do the investments. Training of healthcare workers, on mentorship, we used to do what's called residential training, which became very expensive. We came up with mentorship training, which has really allowed us to reach more health workers on the capacity of their skills. We have also looked at the strengthening curriculum and capacity of faculties at the pre-service level to deliver key reproductive health competencies, because it's very expensive. Once you have an opportunity in school, the mid-level colleges, medical training colleges, and the universities that are providing, that are training midwives, doctors, clinical officers, and midwife nurses to ensure that the products of these institutions are fit for the market. And the market requires people who can understand, visualize, and share the common vision of using maternal and child mortality. So, inclusion of essential MNH services in the essential benefit package for UHC ensures sustainable funding. We are undergoing a health transformation. I'm sure you are following on the social media the universal health coverage and the social health authority that has been established, where it's now becoming mandatory for every Kenyan to be on social health insurance. If you are indigent and you can't afford, the government pays for you. If you are working or you have an informal employee, where we look at using the means testing to gauge your level of income, and you pay 2.75% of your income for social health insurance. Strengthening of data for that decision making is an entity that we are working on. That is why we are robust on actually challenging the global authorities that are putting our maternal mortality higher than in South Sudan sometimes. We are working together to come at a harmonized position on what really is our MMR and NMR. With those 3 months, I can see I was given a green paper there. Is it time is over, or you are worrying me my time is about to be? 5 minutes, thank you. So, the social health insurance means that everybody is a transformation on the health financing component. We used to have the civil servants and only the employed who used to pay for their premiums. Now we have 3 different funds. We have primary healthcare fund, which is fully paid for by the government, and everybody, whether you are poor or rich, can access the primary healthcare level of services, level 2 and level 3 for free. Then we also have what's called critical care, emergency care, and chronic disease care, which is also fully paid by government. And then we have the one, the contributory fund, which is called SHIFT, Social Health Insurance Fund, where individuals who are employed or who have a source of income will pay for their premium, and they have access to a raft of tariffs and benefits through both private and public aid-based health facilities. In this way, we believe it's difficult, it's a difficult journey, it's a mouthful to swallow and to chew, but we are up to it, and we believe instead of the Linda Mama covering only the mother, that Linda Mama portion of the public fund will be transferred so that it can cover the whole family. So if the pregnant mother is paid for, then the whole family is covered. And that way, we believe we can cover more people and create more equity in service delivery. And we believe this will also affect maternal, newborn, and child health reduction in its eventuality. With those few remarks, I have to say thank you.
Thank you so much, Dr. Bashir, for that comprehensive analysis and presentation of the experience of Kenya. So I think Kenya has made significant investments to improve access to healthcare over the last decade, and specifically regarding maternal mortality ratio and newborn mortality rates. I think the report is that these are currently stagnant. But I think they have been able to use their data to reflect that what they need to do is to focus on the quality of care. If you look at their process indicators, it's all looking very good. Up to 98% coverage for antenatal care, which is fantastic. But when you dig deeper in terms of women having the sort of 8 contacts, there's more work to be done. On the 5 mortality rates, as reported, has improved, which is quite good. Also, skilled attendance at birth has improved, significantly, approaching 90%. But I think the message is really clear here in terms of what needs to be done to improve this access, improve the quality of those women who are coming through the door so that they have good quality of care. And I think the countries, in their analysis, they have really localized the sub-national areas where there are real challenges, not just in health, but also in other social determinants of health. And he mentioned the arid and semi-arid regions where the indicators are probably not progressing as quickly as other parts of the country. And I'm sure the country will focus on those areas. Postnatal care, looks good, some work to be done there, and I think they are quite conscious of this. Also, it's good to see from their presentation how they are aligned with a lot of the global initiatives. So he mentioned the rapid adoption of a PPH reduction strategy. So if you look at the biggest contribution to direct causes of maternal deaths, it's postpartum hemorrhage. And the focus on this area, the strategic plan, based on the calculations from WHO, this will give us the quickest return on investments. So I think the assumption is that whatever success was recorded from the emotive trial, we should be able to replicate this on a large scale. So at this point, for that plan, I am on my knees praying that it happens that way. Because as you know, once we move from a research environment to scaling up, I think it's a completely different kettle of fish. Reproducing what happened in those trial facilities into the wider picture. But I think there's a plan. Also, the Everyday Born Action Plan, Ending Preventable Maternal Mortality Action Plan, is a global initiative. And I think they have worked with WHO to get a national plan to move things forward. So all of these initiatives will help, improve the numbers. He talked about their approach to training. They have moved a significant shift from residential-based training to on-site training using the mentorship approach, which is a good thing to see. And there's a huge focus driven by the current government to reduce those financial barriers to accessing healthcare, not only for the family, for the woman and the baby, but also for the entire family. And he gave details of the new social insurance scheme. Finally, I think he expressed something which they are not very comfortable with, which he whispered to my ear, and I promised to discuss that in detail. This is about the differences between the maternal mortality ratio reported through the demographic and health surveys and those ones reported by the WHO. And there's a discrepancy. If you understand how the WHO makes their estimates, you will see that at times there's a missed opportunity by countries to really engage in that process. And I'll just use this opportunity. I always use this opportunity when I have it to explain that process because I'm part of the WHO group. So I think I have to be part of the advocates. So what WHO proposes is that we all use the gold standard for measuring deaths and births. That is by instituting vital registration system. So what it means is that it is mandatory for all births and deaths to be registered in the country. And you take this to scale. That way you are not estimating, you are not guessing. So every death is certified and this is recorded in a database. And then we can know for sure how many women are giving birth, how many babies are born, how many women died. This system is not so strong in most of the countries with the highest burden of maternal deaths. Few women are giving birth in facilities. A lot of women will give birth at home and die, and they do not get recorded in the system. A lot of women will die in first trimester. Nobody knows they are pregnant. We've heard the report, very few women are going for antenatal care in the first trimester. We are all African. We know some of the myths around these things. You know, if you start telling people that you're pregnant before it starts showing, then maybe the spirits will take the baby away. So all those type of things. So it's possible complications happen and people just die pregnant and nobody knows. So we did not count it. We did not learn from it. So with all of these issues, what it means is that, you know, we can't underestimate how many women die. Then I think the biggest one that we forget, what we do in our countries is that we do demographic and health surveys. Demographic and health surveys will be done maybe every 5 years or every 5, 6, 7 years. But using the methodology they use is a sampling methodology. The sampling in itself has an error. That's one. Two, the questions they ask refer to deaths that have occurred from a period of 0 years, that year the measurement is taking place, up to 6 years before. So that what it means is that at the time the results are published, is giving you the pictures probably some time back. And when you look at it, the margin of error, the interval, the confidence interval of those estimates is so large. So what the WHO does is to use some mathematical modeling. They take all the measurements of maternal mortality from that country, put it as part of a model to come up with something accurate. They make adjustments for all those errors. And the more data points they can put into that formula, the better. So they first do the calculations, then they go to the countries to ask if there's any new data. They add it into the formula. When they come up with the estimates, they run the second level of consultation with countries. So now that I've got you interested in this methodology, my challenge to you, when you have time, download the current estimates for maternal mortality from the WHO. It was published in May 2023, I think. If you look at Annex 1 and 2, it will give you an idea of the corrections they have made and the compliance with the consultation by countries to sign off on their figures. And you will see that the compliance could be better. So at some point or the other, you know, somebody either has not signed off or has not made contribution. They have now published what it is. So that's why you can have some discrepancy in some of the data that is produced. And now, just a heads up, next year we're going to have an updated WHO estimates. These estimates will report on what the numbers are about 5 years to the end of the SDGs, but will also report on to what extent did COVID-19 affect maternal mortality in countries. So we are going to see that is coming out next year, the first half of the year. So that's something to look out for. Now, for some countries, if you look at the reductions, finally, for some countries, if you look at the reduction they have made in maternal mortality, compare their demographic and health survey results to WHO estimates, the trend is the same. The trend is the same. So that just gives you some level of confidence in that approach. So my plea to Ministry of Health colleagues is to keep driving the agenda for better measurement. That will be on the vital registration system. Because if we have those registration systems close to 100%, then there's no controversy, there's no argument, isn't it? You know, we nail it and then everybody is happy. But I think it's a dialogue. We will continue to make sure that we get inputs from those at national level. Now, let me tell you what the WHO estimates will not do, and this is where the demographic and health survey is strong. The WHO estimates will not give you data on sub-national level. It will not tell you one region or county, it will not give you that, it will give you on the national level. What demographic and health survey does, it gives you a relative idea by sub-national level and can help you focus interventions, just like what Dr. Bashir has described in the arid and sub-arid regions. So colleagues, I hope that ramble was worth your while. And I will move swiftly to the next speaker. But please join me at this point to thank again Dr. Bashir for his detailed presentation. Good. So we're going to move on to Nigeria. So it's my pleasure to invite Dr. Henry Jambo to speak on the situation in Nigeria and the experience. And I'm sure, as always, we'll have something to learn. Thank you. You're welcome.
Thank you so much. So I was going to go through a brief presentation. I'll try and be quick with it. But I'm working on the following outlines, looking at the background, briefly talking on situation analysis, talking about our national POC MPCSR. Then we'll look at our national health system development policy architecture, our RAMCAR life cost strategy in the country. We also want to talk about what we're doing on calibrated rates for issues of leakage. We'll talk about group ANC that we are also looking in the country and stable capital C. And look at what we are doing on maternal health commodities and also logistic management for that. So we're looking at what we have been doing since 2016. We're looking at how we are working with the ANC model for WHO, looking about contacts and the benefit of these contacts when it comes to maternal health care outcomes for our women in Nigeria. So we have moved from the FANC, which was we are doing before now, moved over to the WHO model fully within a country. We believe that this has also helped us with our indices going forward, and also we have also gone ahead to do some work on group antenatal care. Piloted about 4 states in the country and some facilities, and we're trying to see how we can roll that out at those facilities whereby all the benefits are well noted, because we realize that it is not only facilities that have the personnel to carry out group antenatal care. So it's only in those facilities whereby we have enough personnel and enough hands on ground, skilled bed attendants, skilled facility personnel to carry out group antenatal care. So looking at our situation analysis, we have rough estimates. We have not been able to handle our census, so we're still working on rough estimates. Some data you will have, we see Nigeria has a population of 230, some say 250 million people at different locations. Our antenatal care attendance is 67%, and skilled attendance at 43%. But we found out that at delivery we have a far less figure. Then we look at our maternal mortality ratio. This has remained the same for our NHS. It was 512 per 100,000, which was quite high, and we did not see any substantial change over the years. So this year we have had our NHS 2024. The data and results for the NHS 2024 will be coming out hopefully before the end of this year. And right now we are training data collectors for our verbal autopsy. So very soon we also have information on verbal autopsy. The unique thing about our NHS this time around is that we are going to be doing direct MMR, not the sisterhood method any longer, but we still have data for sisterhood methods that we can still plot the graph to find out trends, which is also very important. So we did a lot of investment on that aspect. So our neonatal mortality rate is 67 per 1,000 live births, while on the 5 rate is 132 per 1,000 live births. What we also noticed that in Nigeria is that we have annual fertility rates of 5.3. But this annual fertility rate of 5.3, let's say that in the rural aspects or the poorer regions of Nigeria, the fertility rates can be as high as 7 or even more, while for the more affluent areas it could be as low as 4. So that's what we have noticed, and that means that we have to push a lot for our family planning strategies, contraceptive prevalence rates, and uptake of family planning, and also look at other contraceptive rates in country. So looking at furthermore, before I go into the QC, MPC, we're looking at our ENC by skilled attendance. As I said before, it was 67%, while ANC, our focus antenatal care, we found that it was about 57%. For delivery, as health facility, it was as low as 39%. So we found that there's a serious issue, there's a gap there. When we talk about delivery at health facility, yes, the patients they present for ENC, why are they not coming for delivery? That has been the issue. So that gap is what we have been trying to resolve with QC, MPC, DSR. Is it that there's an issue with our quality services that our healthcare workers are providing for our clients? So we try to address issues of experience of care through our QC policies and rest of that. And that's necessitated us to quickly look at how to improve on our strategy. So these are some of the strategies and our targets that we did this year. We have worked on our documents, our strategic document this year. So we came up with some of these key targets for this year. So 63% reduction in institutional maternal deaths, reduction in institutional deaths from 2024 to 2028. It's quite ambitious, but when I go forward, you see some of my presentations while we are putting such targets because of the new innovations that are coming on ground when it comes to maternal health across the country. So we look at reduction in institutional still death rates, increase the number of women with positive pregnancy experience, and increase in proportion of adolescents accessing services, increase in the proportion of older persons receiving quality essential care services at the PHC in the community. Nigeria is the only country at the moment that is looking at bringing in elderly care into our RAMCA strategy. We believe that it's very, very important for us not to segregate the elderly. So we have created indicators for the elderly and we're moving forward with that. So that's why it's part of our target. So one of the things that the innovations that we brought on ground on our quality of care MPCDSR was that we initially were having parallel programs for quality of care MPCDSR both at the facility and at the sub-national levels and at the national level. But we said no. MPCDSR at the end of the day still talks about quality at the end of the day, and at the end of the day we said no, we should have one focal person, one program, one strategy, and one drive for funding. So we were able to bring a single coordination platform, strategy and guidelines for QC and PCSR. We were able to have clear roles and responsibilities for facility QI teams. When we started, Nigeria was one of the first countries that was able to be part of the initial move by the international communities, the first 11 countries that started up on QC. So we were able to build on that. With our pilots, states pilot facilities, we have expanded from that now, and we are across our 36 states and the FCT, which is our federal capital territory. We now have QC across board. Most of the facilities are now rolling into the QC, and this was made possible because of the basic healthcare provision fund that we have. So I will still talk about that going forward. That has allowed us from the country to fund our programs by looking at funding in country for our healthcare services. So look at buying by National Council on Health. We have the National Council of Health from all the sub-national levels that sits together alongside with the Honorable Minister of Health, Honorable Minister of State for Health, to make policies, look at memos and move forward on national plans on health. We have our monitoring, evaluation and accountability learning plans that we have developed. We have the RAMCA policy of training manual. This helps us to make sure that we have a harmonized training system across the continent. Nigeria is quite a large country. Can imagine a population of over 230 million. It's very important for us to have an harmonized training program when it talks about e-models, training models, mentorship, coaching, all things that captured in this training manual. So that we have a harmonized training manual. We also have different tiers in Nigeria. We have the tertiary, secondary, and primary. So we also have training manuals clearly stated out. We have annual vocational plans and our technical briefs. We have our e-learning platform launched and ready to use. If we go online now, check on the e-learning platform for RAMCA quality of care. We see e-learning platform whereby we have all our documents, all our information, and also states have the opportunity to put in best experiences, challenges, mentorship, and trainings can also take place on that platform. So we have our HIS2 and local reporting platforms reporting on quality of care and NPCSR, and already harmonization on this platform has already started right now. So that it's possible for you to move from one platform to the next platform, and also for you to see information both on QC and NOCA. NOCA was initially brought up for NPCSR applications. So we're trying to do that now. So look at National Health System Development Policy Architecture. We have the current administration of the federal government is looking at the whole agenda for the country, and that necessitated us to look at what we can do in the health system. Because of Nigeria is having issues with human resource for health. In recent times, we're having move by healthcare professionals leaving the country, and we have seen some gaps. So we have started this reform process and agenda. So these are the health sector strategic blueprint, which was developed. Look at the initiative, which is the health sector human investment initiative. Look at the SWAP, which is Focus Blueprint Initiative. We want to look at the ACPF, as I said before, Basic Healthcare Provision Program, and Healthcare Industrialization Program. We found out that we are losing so much money when it comes to commodities, procurement, and the rest of them. So we looked at a healthcare industrialization program whereby we can start producing some of those medications, some of those drugs that are our routine medications that we use for our women and our children to be produced in country, and also for those basic equipment to be produced in country. So we are looking at that. So furthermore, the Basic Healthcare Provision Fund comprises of at least 1% of the consolidated revenue funds for the country. So the consolidated revenue fund for the country, 1% has been set aside for this. So the goal of this is to double the number of PHCs receiving decentralized facility financing for infrastructure upgrades and operational costs to ensure delivery of high-quality essential permanent healthcare package, including immunization, family planning, antenatal care, postnatal care, and to meet the BMOC for the country. So what we are looking at is the health facilities to move our facility numbers from 8,800 to about 17,000, as you can see, by 2027. And already we have already started this process in country. We are building structures, we are remodeling structures, we are equipping structures, and through the new CPS fund, we are able to employ through contracts more volunteers to work in the primary healthcare centers to bridge the gaps we have, since I talked about human resource of health issues. We have linking of PHCs to secondary care facilities, providing comprehensive emergency obstetric and newborn care. So we also have linkages whereby 4 primary healthcare centers are linked to one general hospital for easy referral purposes. You have double referral forms and everything to make sure that at least our women do not have any issues when it comes to referral. So we're trying to strengthen that referral pathway for our women in country. So looking at health sector strategic blueprints, what does it look at? We look at effective governance. So we noted that we have a duplicity of governance structures in country. So we are trying to streamline everything for effective governance, efficient, equitable, and quality health systems, unlocking value chain, health security, data digitalization, financing, culture, and talent. If I want to do a little bit on data digitalization, we have been able to push for all our tertiary hospitals to be on electronic EMR, electronic records keeping. So now all our tertiary facilities in country are on this. We have gotten commitment from our sub-national levels for all general hospitals to be on EMR. So that is being rolled out across board, and also the PHCs, those that are model PHCs and comprehensive PHCs and CR, 3-level PHCs are also on this EMR subsequently. So as time goes on, we try to make sure that we connect that EMR process directly to our HIS2 platform so that our data will be on time and live. So that's what we're trying to do. Looking at culture and talent, issues of experience of care, challenges of experience of care, all these are addressed in this blueprint. So I want to also look at the sector-wide approach, as I talked about. The sector-wide approach is also one of the duties of our coordinating Minister of Health. It looks at the tenets of it is one plan. So now what we are doing now is that we're going to be sitting down with all our development partners, all our NGOs, and all our sub-national levels and federal governments. We're going to sit down together to produce a national plan for health in country. So as we know where our resources are going to reduce issues of obesity. One budget will have more like in basket funding. Yes, you may not take your fund as a partner, but you want to know what you are putting in country to make sure that there is no waste at the end of the day. We're looking at one report. At the end of the day, the report you are sending to your funders, if you are an NGO or a sub-national level, should be the same report, so that we do not have issues of bundling of reports and miscalculation of what is really happening in countries. So the country also knows the data that is going out of the country. So if there are any issues that we want to resolve, we can resolve those issues and address it. One conversation. Everybody has a voice. Everybody sits around the table. Everybody sees their issues, their problems, and provides solutions to those issues where it is possible. So what we're looking at, Anchor does send life course, look at the productive maternity born child adolescent health, as my initial colleague has also talked about. Look at sub-national level Department of Family Health. One of the issues we notice at our sub-national levels is that there's a disconnect between the national and the sub-national level. So what we are trying to do is to make sure that what we have at the national level, at the sub-national level, by having the Department of Family Health, and also that Department of Family Health speaking across the life course at the end of the day, so that we'll be able to have a more integrated approach for HIV, TB, maternal health, reproductive health, child health, adolescents, and elderly on board. Look at integrated approaches, strategy, and implementation, single coordination structure of steering committee and technical working group. We have multiple technical working group. It means that so much money is spent on technical working group meetings and steering committee meetings, which at the end of the day we are not able to achieve so much. So now we say no. For the national level, we just have one steering committee. So anything they want to discuss, come to that steering committee, we'll discuss about that. The steering committee has different TWGs that feed into it, such as Department of Family Health, Hospital Services, public health, like the case may be. So we all report at the end of the day to that single coordination structure. So looking at the calibrated grips, what we are pushing for our PPH is the use of calibrated grips. Already we have started the process in country. We have policies and everything in place. What all we are doing is rolling out little by little to our health facilities, picking up from our PHCs, general hospital and tertiary facilities. So we are moving at light speed with this to make sure that at the end of the day, we are able to do a proper estimation of what happens. Just a few minutes, 1 moment of the two. So Group ANC, as I talked earlier, we have this stable Karibu Zantime. It's being rolled out across the country. You know that some of our health facilities now do not have this stable Karibu Zantime. Issues we are having with oxytocin is that when it talks about preservation or storage in at a certain temperature, we may have power outages like this. So this stable Karibu Zantime, we are going to move that out of the way to make sure that at least PPH is reduced due to having this stable Karibu Zantime. There are about maternal health commodities for sick management systems. We have oxytocin, misoprostol, the following medications, and even much more that are there. Now, the Nigerian government has started the process of procuring such medications and trying to see how we can distribute it across board. So, our initiative was just family planning commodities that we are procuring. And sub-national levels now, different states are bringing their own funding to the national baskets and also to the development partners' baskets to buy together, procure together, reduce issues of obesity, costs for logistics, transportation, and everything. So we do everything together, bringing our family planning commodities, bringing our maternal health commodities together, requisition, distribution, and procurement of these state commodities. So thank you so much.